Uh, Good morning. First, I would like to congratulate Siddharth for such a beautiful lecture and on a difficult topic, which I am still confused, as you would have realized from my questions. But very well taken. Thank you very much for that. So now I'll be talking about minimal invasive cardiac surgery, present and future. I will try to base my topic on the evidence, a bit of scientific data, and then, as usual, the topic is like for all of us to decide what the present scenario is and what the future should be. So this is an interesting. This was an interesting, actually. The line which I have taken from this article, this was a review article, and it says recent development in minimal invasive cardiac surgery, evolution or revolution. So it actually, if we think about this, it is much more of revolution when it started, and revolution usually do not last very long. So and they have some purpose, and if revolution doesn't have a purpose, then it is futile. So if we talk of why this revolution started, we actually started competing with cardiologists, and we started thinking of newer and better ideas of making our product more visible and better seen to the public and to the cardiologist also. However, what we have been talking about, the benefits of MICS, considering it to be a revolution, is it creates less pain, which is a false narrative. It creates more pain than stenotomy. It has less blood transfusion. That is true. Fewer wound infection. Yes. Less pulmonary complications, plus minus. Faster recovery. Yes. Except for pain. Yes. And better cosmetic results, definitely. So are these the traditional benefits of MICS, what we are talking of? Are we just looking at them, or are we looking at broader or better outcomes with minimal invasive cardiac surgery? So if we slightly take, I should say, support of evidence, evidence has been gathering in favor of minimal invasive cardiac surgery, which possibly either we are not very well aware of, or we do not actually scientifically mix our revolution with this evidence. So this is 1999 paper, which says there is complement activation. And this complement activation is much more when we do stenotomy. We know this. Most of us know this. So this, when there is an inflammatory scenario which is created by doing stenotomy, which brings a cytokine storm in the body, and when you are comparing it with a non-stenotomy incisions or small thoracotomy incisions, the complement activation is much less. The other evidence is cardiopulmonary bypass. So if we use stenotomy and we do thoracotomy, and we use cardiopulmonary bypass, so what happens? What is the difference in inflammation in these groups? So this is an experimental study, but this has very nicely demonstrated that 30 minutes of bypass, 60 minutes of bypass actually is in favor of thoracotomy and bypass. Complement activation is less and inflammation is less as compared to group which had stenotomy. Now this advantage is lost if bypass is long. Unfortunately, at this point of time, we are doing minimal invasive surgery where we take slightly more time, because minimal invasive cardiac surgery is yet developing. That is what I feel. Then the influence of inflammation, as we have already discussed, and coagulation. What happens to the coagulation profile? We talked that there is less bleeding after minimal invasive surgery. So this evidence in humans, they have shown that there is less coagulation problems and less inflammation in thoracotomy incision than sternotomy incision. And that probably is the reason why we are seeing less pulmonary complications, lesser blood loss in patients when we do minimal invasive surgery. Now, I will take one thing at a time. Minimal invasive cardiac surgery is a big topic. So we do valve surgeries for this. We have coronary surgeries in this conundrum. So let us start from aortic valve surgery. And this is interesting analysis from Lamella's group, which is a very strong proponent of median mini sternotomy AVRs. Now, interestingly, if we see at this point of time, much more mitral valves are repaired through minimal invasive than aortic valves. We'll see what the evidence of speaks, either it's in favor of mitral valve or an aortic valve later. But why aortic valve is done less is because there are issues in aortic valve. We were discussing yesterday, should we go by upper hemisternotomy? Should we go by rat incision? So there are considerations. So there are basically challenges for the surgeon, whether he'll be able to see the valve nicely, would be able to excise the valve nicely. The issues of giving cardioplegia to the right coronary ostium, the issue of taking sutures on right coronary cusp. So those are issues which still dog us, and we are doing less of minimal invasive aortic valve. And if we see these 11 articles which they have analyzed, which have reported minimal invasive aortic valve surgery through either rat incision or a hemisternotomy, we would realize that out of this study, out of these 11, 8 are favoring minimal invasive cardiac surgery. And this is favoring in sense that was less mortality. Only 2 studies are favoring sternotomy. So that is the hardest point which is available to us in analyzing results of 2 operations. So if we again see this meta-analysis from Leipzig group, they have shown clearly that in unmatched population, the mortality with minimal invasive AVR was less and significantly less. And when they were matched, still this significantly improved outcome with minimal invasive AVR was there. And to our irony, we are using less of minimal invasive AVRs. So we have to think about this. Actually, AVR is the operation. Considering this evidence, we should be doing minimal invasive. When we talk of minimal invasive mitral valve replacement or repairs, it's about 25% in USA, and almost half of the repairs or replacement in Germany is done through minimal invasive. So why is there more acceptance of minimal invasive MVRs with us? Because the incision is very clear. You gain size on the 4th intercostal space, you will see the left atrium right in front of you. The mitral valve is facing the surgeon. When the patient is tilted about 30 degrees from supine position, and it can be done with regular instrument also. You need not have very fancy instruments for this. So there is much more acceptance of minimal invasive MVR, and it has appeared as class 2B indication in ISMICS, minimal invasive society criteria. So if we see the meta-analysis in favor or disfavor of mitral valve, what we realize that meta-analysis has shown that the mitral valves, minimal invasive mitral valve surgery do also have favor if we consider mortality as the endpoint. So it favors minimal invasive MVR. But when we take high quality studies, then there is no difference between minimal invasive MVR or sternotomy mortality. So actually this minimal invasive MVR is actually not adding to advantage in mortality, though it may be adding advantage, giving us advantage of less infections. Obviously, there is no sternal infection. It can be easily done. It can be a template for learning minimal invasive approaches, and it definitely causes less bleeding. But minimal invasive mitral valve surgery has a definite role if there is a redo tricuspid valve replacement or repair you have to do. Minimal invasive is good. If you have flowing internal mammary arteries where a bypass grafting was done and you want to do a mitral valve repair or replacement, then minimal invasive approach is good. Obviously, in redo cases, in obesity cases, in high cases with prohibitive pulmonary dysfunction. Now, this is dichotomy. We are talking that minimal invasive mitral valve surgery is not helping us if we are taking primary cases. But when we are talking of advantages of minimal invasive mitral valve surgery, we are talking of all high-risk situations. So this needs to be ironed out. And this just shows that actually, though we may not be able to do minimal invasive mitral valve surgery in almost all cases, though we should. This is the reason why we should be considering these facts and should be surging ahead doing minimal invasive mitral valve surgeries also. So these are what we have already discussed, benefit of minimal invasive valve surgery. Then from minimal invasive valve surgery, we'll move to the benefits are lesser trauma, what we have discussed, avoidance of sternotomy we have discussed. Now, can we avoid cardiopulmonary bypass and manipulation of aorta? We do not touch aorta at all. So this becomes an ideal minimal invasive surgery. We are not touching aorta. We are not going on cardiopulmonary bypass. We are not doing sternotomy, and we are causing less trauma. And that is only available at this point of time with minimal invasive coronary artery bypass grafting, which is less practiced, but is the best operation which we can give, offer to the patient. I'll not go into details of this because it is much more technical, but what I can tell you from the results which we have been pursuing at Sanjay Gandhi PGI, we compared minimal invasive multi-vessel total arterial revascularization with sternotomy, multi-vessel total arterial revascularization, all-cause mortality was similar. When we compare it with our patients, which we received one internal mammary artery to LAD and other veins, there was significant difference in mortality at follow-up of 10 years. So I think this speaks a lot volume about why minimal invasive CABG should be pursued. Now, if we talk about future of CABG, future of minimal invasive cardiac surgery, what are we looking for now? When we are already doing minimal invasive mitral valve, we are already performing minimal invasive aortic valve replacements. What more do we want? So for it to become more standardized, for it to be accepted by more surgeons, the vision should be better. The control of instrument inside the chest cavity should be better. The incision should be least, and the patient should be discharged very early. And if I talk of these things, we all think about robot. So that is the future, that it gives you a fantastic vision. It gives you a fantastic control on instruments. The incision is minimal and the patient can be discharged just in one day. As well, he would have got a stenting done with cardiologist or a valve procedure done in cardiology. Now, I would love to share my view on minimal invasive valve surgery. So if we want to basically bring everything to one incision, suppose you give one incision and you are able to do a mitral valve, tricuspid valve, aortic valve, or a double valve. Then this approach of going through axilla, I have found that this can be a single approach which can help us in performing all the valve surgeries. The incision is given in axilla, and the entry is done through the fourth space. Obviously, we went all the left atriums in mitral valves as well as aortic valves. This incision is made and anterior axillary line in fifth intercostal space, from which a cannula can be put. This is after cardiopulmonary bypass, femoral. You can see the aorta nicely. The aorta is there. You have to use long instrument. It makes it much easier. So what we can see here is this is the left atrium, which is very clearly seen right in front of us. This is aorta almost in front of us. The only problem in axillary incision is the lungs of our patients are bad. They won't go down just by disconnecting the patient from ventilator. So the incision should be right at the pectoral muscle. So actually it is, I would say, anterior axillary line. It should be just abutting at the anterior axillary line. This is the cannula is which is being put. The other thing which I would suggest, this is the left atrial retractor which is being put through a separate incision anteriorly. I use Felling instrument, so this is one of the Felling's retractor. But now there are at least three companies which are making left atrial retractors, and those can be used. I'll just go forward. I'm just trying to show you that this single incision can actually give us access to almost all the valves. So this field is dry, much better. This is planning to put a clamp. It is important to lift the aorta in the transverse sinus and see whether the clamp is not going to injure the left atrial appendage. The mitral valve is seen right in front of us. So that is the beauty of this incision. I have measured the distance between the thoracic wall internally and the pericardium. That distance in 10 patients was mean was around 10 centimeters. So if we take pericardial stay incisions and pull the pericardium up by at least 3 centimeters, the distance between the skin incision and the heart would be about 6 centimeters. And that gives much more confidence to the surgeon. It appears that axilla is quite away from the heart, but in actual it is not. And you can see the mitral valve is so clearly seen right in front of us. We just need some long instrument to be comfortable. What I would suggest is we must start using prefabricated knots. That is core knot. That will make the whole experience much more enjoyable. The other interesting part in mitral valve surgery is you can put the stool up and like a bar stool, and you would be sitting on the stool like you sit on the bar, and you can do the operation sitting. So that is the fantastic, that is quite relaxing. Your back is straight and you're sitting on the stool and you are enjoying the operation. And when you come off, use of carbon dioxide is important. And when you come off, the important thing would be you come off from pump, you stop when you are happy that on TOE there is no air inside the heart. Go on full pump, take out the cardioplegia cannula, you stitch the hole there, and then you come off pump. Before you release clamp, put a pacing wire, because it becomes very difficult to put a pacing wire once you have released the aortic clamp. And this, I think this single technique, this single incision can give us access to almost all the valves, and we would be repairing much more valves using minimal invasive technique. Transesophageal echocardiography is the mainstay which guides the cannulation and which guides the whole operation till the finish of this spectacle. Thank you.